I'm Dr. Su. Again, I work at the VA and UW, so I see some of my patients listening in. So hello again. So today we're going to talk about the non-motor symptoms. I know we have a lot of talks about motor symptoms like the tremors, the stiffness, but we'll focus today's talk about non-motor symptoms. There's a lot of information in this presentation. Don't sit there writing down notes, just absorb the information. You'll get the slides at the end, and so you can go back and reference them later on, okay? Okay. No disclosures besides the fact that I have allergies. And just before we start, I don't want to overwhelm you. Sometimes I feel this talk sometimes can be a bit overwhelming because there's a lot of symptoms we go over and people start thinking, oh my gosh, are all these symptoms going to happen to me? That is not my goal of this talk. My goal is not to have you feel like this, but rather feel like you have the knowledge to power yourself as you're dealing with Parkinson's disease and know how to reach out to your Parkinson's disease expert, okay? So that is my goal. This is my goal. If I don't achieve this goal, you let me know, okay? So just let's start with a very basic overview of Parkinson's again, just to start off the talk. So it's the second most common neurodegenerative disease after Alzheimer's. It affects approximately 7 million people globally and 1 million people in the United States. The prevalence is about 1 to 2% in the 65 and older population and 4% in the 80 and over population. The average age of onset is about 60 years, though there are a couple of cases, 5 to 10% of cases, that can occur in younger ages between 20 and 50, and we classify this as young onset PD. So for motor symptoms, which you're probably very familiar with, some people have tremors, not everyone. A lot of people have tremors. And again, it's usually starting on one side, it's a resting tremor, and it has a pill rolling quality to it. People then have rigidity or stiffness, and sometimes it feels like your joints are very ratchety. Parkinson's patients also have what we call slowed movements or loss of movements called akinesia and bradykinesia. And this can manifest in different ways. It can show up in your face, like having a masked face, having a softer voice, having drooling, shuffling walk, and then smaller handwriting as kind of shown on the right, where when you're off your meds, you write very small and it's hard to read. And then lastly, patients for motor symptoms can have some postural issues, balance issues, and have increased risk for falls. And what is the cause of the Parkinson's disease symptoms? Well, there are cells in the brain that are very important because they produce a chemical messenger called dopamine. And some of these nerve cells in Parkinson's disease patients have died or have become impaired, so they cannot make as much dopamine as before. And this really impacts the messaging between cells, allowing you to move. There are changes that happen in Parkinson's disease brains, and this is due to accumulation of proteins in the brain. These protein accumulations are called Lewy bodies, and Frederick Lewy is the one who described these microscopic particles that is affected in Parkinson's brains, and named it after himself, Lewy bodies. This was in 1912. And these Lewy bodies are composed again of these accumulated protein called alpha-synuclein. And these develop in the cells and impair the cell's ability to function. So this is what a Lewy body looks like in the cell. The cell on the bottom right is the one that has a Lewy body, this round pink structure. And because of the presence of this protein accumulation, this cell cannot properly function, properly make dopamine, and thus patients develop motor issues and then also the non-motor issues. This slide just briefly shows that there are changes in the brain that happen with the accumulation of the Lewy bodies in the cells. And this is the part of the brain that is involved in the motor functions of Parkinson's disease. In the typical patient without Parkinson's, there's lots of cells that make lots of dopamine and also lots of pigment that makes the cells look dark. And so on the top structure, that's a patient who does not have Parkinson's, has plenty of cells making pigment and dopamine. In a patient with Parkinson's disease, there's less cells. So less cells that make dopamine, less cells that make pigment. And so this area looks much lighter. And so this is a part of the brain called the substantia nigra, and it's important for motor function. But cell loss does not only occur in parts of the brain involved in motor control in Parkinson's disease. There are also cell loss in many other places of the nervous system that control the non-motor symptoms. And that's what we're going to talk about today, all the different types of non-motor symptoms, okay? So let's introduce the Parkinson's iceberg. So like an iceberg, there's things that poke out from the surface, and these are things you see. And those are the things that you see and other people around you see that are associated with the Parkinson's disease. So that's the tremor that you might have, the stiffness that you might have, the slowness that you might have, the stoop posture that you might have. But under the surface, under the Parkinson's iceberg, there are several symptoms that are also due to Parkinson's disease that you might not be aware are associated with Parkinson's, or the people around you might not be aware are associated with Parkinson's disease. And so this is what the talk's going to be about. You'll see there's lots of different symptoms, and we're going to talk about many of them, but not all of them. And so we're going to go through this the list is coming up. We're going to go through several of them, the ones that I feel are the most important ones that I discuss the most with my patients in clinic. I will say often the non-motor symptoms can be more troublesome than the motor symptoms. You know, people are bothered by tremors and stiffness, but some of those other motor symptoms, when they progress, can be very problematic. And so I want to be able to give you the understanding of how to manage these symptoms and awareness that these symptoms might be due to your Parkinson's disease. Okay, this is just kind of a picture of the different areas of your body that may be affected by your Parkinson's disease, including how well you think, your vision, your heart rate, your blood pressure, your gut, your bladder, etc. So we'll go through many of these in the upcoming talk. So these are the symptoms that I have decided to talk about today. So they're a good variety, and I hope I can address them enough so you have an understanding of what kind of symptoms they are and how to manage them in both medications and also non-medication management strategies. So let's start off with pain. So pain is a very common but sometimes under-recognized symptom in Parkinson's disease. It is present in up to 85% of patients with PD, and up to 63% of this pain may be due to the Parkinson's disease itself. Many PD patients consider pain as one of their top 3 most bothersome symptoms and can really affect quality of life. So pain management is largely determined by the underlying cause of the pain, because there's many different types of pain. So you could have musculoskeletal pain. For instance, like me, I unfortunately have some bad tendonitis, and so I'm wearing my wrist brace. So you could have arthritis, and that's a very different pain from having stiffness in your arms and legs from your Parkinson's disease. Some people have neuropathic pain, which is nerve pain, often from issues like diabetes. And this kind of can be a very different kind of pain, a burning pain, a tingling pain, a sharp pain. And then another form of pain are the extra wiggly movements someone might have, the dyskinesias. When they're very big movements, they can be bothersome for certain patients. So our management of pain depends on what that pain type is. So if it's because your medications are not, your Parkinson's medications are not going so well, you're having lots of off periods, lots of motor fluctuations, lots of stiffness, lots of dyskinesias, that may warrant discussing with your Parkinson's disease expert about how to adjust your medication regimen to reduce the off periods, to improve the dystonia, to lessen the dyskinesia. If it's neuropathic pain, so again, this is that nerve pain that many people have due to things like sciatica or due to diabetes. it's managed differently. It's using medications that calm down the nerves. And some of you might be on these. There's gabapentin, pregabalin, which is Lyrica, duloxetine, which is Cymbalta, nortriptyline. And some people use topical creams and find benefit there. There's also the musculoskeletal pain. Again, those are the joints, the aches and creaks in your joints. So for those, we like to use medications that reduce inflammation. So NSAIDs, Tylenol, topical creams like diclofenac gel, for instance. When it comes to medications, of course, we have to be mindful. Medications can come with side effects, so we want to make sure we can manage the pain without causing new undesirable side effects. For instance, gabapentin, very commonly used in neuropathy, unfortunately, for some patients can cause many side effects such as drowsiness, dizziness, unsteadiness, and some cognitive fogginess. So just be mindful of that you can treat the pain, but you don't want to add more problems to the list. For NSAIDs, the problem using it long-term is you can develop issues in your gut like stomach upset and ulcers. So there are other non-medication options of managing pain, and I will emphasize the number one on the top of this list, exercise, many times throughout the course of this talk, because exercise is so important for all Parkinson's patients. So I really hope that you have some exercise as part of your daily regimen. So exercise can help with pain. Seeing a physical therapist can help with pain. They can give you ways to strengthen the muscles, stretches, etc. Massage, acupuncture can be also very helpful. Chiropractors for the low back. I usually say no chiropractic care for the upper neck just because some of their manipulations have a risk for developing strokes. But low back, A-okay from my standpoint. There's also different relaxation techniques that can be helpful, like mindfulness, meditation, and then other types of exercises that include relaxation techniques like yoga and Tai Chi. Heat and cold packs can be helpful. And in some patients who have such stiffness in their arms or their legs or their neck, sometimes we will put in some Botox into those muscles and relax those muscles, and that can be helpful as well with pain. Okay, so that was our first one, pain. So next up, we're going to go to sleep issues. So sleep issues, common complaints patients might tell me include difficulties falling asleep or staying asleep. Daytime sleepiness with sleep attacks, just all of a sudden, boom, you're out and you're sleeping. Sleep fragmentation, so you fall asleep, but then you keep on waking up throughout the night. And then very importantly for Parkinson's patients, REM sleep behavior disorder, or RBD, which is acting out of your dreams. So let's start with RBD because it's such a pivotal component of Parkinson's disease. So REM sleep behavior disorder, or RBD, it involves a certain stage of sleep called the REM sleep, rapid eye movement sleep. So your active dreaming occurs at this stage of sleep, and this stage of sleep happens many times overnight. Usually during this stage of sleep, your eyes will move a lot. That's why it's called rapid eye movement. And you'll breathe just fine. So your diaphragm will breathe. Oh, you'll move just fine. But otherwise, your arms and legs don't move. So you just lie there flat and stiff, but your eyes move a lot and you breathe. But in patients with Parkinson's disease, they don't have this paralysis. They move a lot. In fact, they move too much and they act out their dreams. And that's what we call REM sleep behavior disorder. You might not notice that you have REM sleep behavior disorder. It's oftentimes the people who sleep next to you who are woken up by your acting out of dreams that tell you, hey, you are punching, kicking in the air, shouting, etc. So in terms of all the sleep issues I brought up earlier, they could be sometimes due to side effects from medications. For instance, carbidopa-levodopa in certain patients can cause drowsiness. Ropinirole and pramipexole, so those are the dopamine agonists, can definitely cause sleep attacks. Other things to consider is how good is your sleep hygiene? Are you going to bed but looking at your phone or watching TV? And so that's disrupting sleep. Are there other issues affecting your sleep? For instance, pain, like we talked earlier, or urinary issues. Are you going up to the bathroom 3-4 times at night and causing your sleep to be fragmented? Are you having lots of depression causing your sleep to be not so great? And importantly, do you have undiagnosed sleep apnea? And I will talk about this more in a couple of slides. In terms of management, so sometimes, like I said, some of your Parkinson's medications can cause drowsiness. So your provider can adjust them to try and improve your sleep. So for instance, with like the dopamine agonists like ropinirole, pramipexole, I tend to avoid that if possible during the daytime to avoid the sleepiness, and then aim to use them at nighttime. For some people who on immediate release carbidopa-levodopa are having too much drowsiness, I will switch them over to the longer acting or controlled release, and this helps reduce their drowsiness. And there's another medication that we use in Parkinson's called selegiline. It's an MAOB inhibitor. It prevents the breakdown of dopamine. We often use that in the daytime because it can help with energy, because one of the breakdown products is an amphetamine and gives you a boost of energy. So that's some way we can also improve your wakefulness during the day so you can sleep better at night. So talking about sleep hygiene, and I will say I do not have the best sleep hygiene. So these are all things I also need to work on. So avoid and limit daytime naps. You can nap like after lunch. That's a very good time to nap, but just make it short so it doesn't disrupt your ability to sleep at night. Exercising early in the day can be very helpful because you'll be tired and ready for bed at night. Avoid television, mobile devices, any electronic screens that can be stimulating in the bedroom. Avoid caffeine, alcohol later in the day, and definitely try to avoid drinking too much water at the end of the day. You should drink water at earlier parts of the day because it's important for hydration and your blood pressures. But if you drink too much of water at night, then you'll be up all night going to the bathroom. So let's talk a bit about undiagnosed sleep apnea. So sleep apnea, most importantly, obstructive sleep apnea, is when your airway is blocked at night and you have periods of time when you stop breathing and don't get good oxygen to your brain. And this can happen when you're sleeping on your back, your tongue falls into your airway, and then it blocks the airflow, as seen on the right. This is a questionnaire that we use a lot for diagnosing sleep apnea. It's called the stop bang. And if you have just a quick moment to kind of run through these questions and see what your score is, you can get a sense of if you're at high risk, medium risk, or low risk for developing sleep apnea. So importantly, do you snore at night? Do you feel tired during the day? Has anyone observed that you stop breathing or choke or gasp in your sleep? Do you have high blood pressure? Do you have a BMI over 35? Are you over age 50? Do you have a bigger neck circumference? And are you male? So these are all factors that make it that make you higher or lower risk for sleep apnea. So if you didn't have a chance to do the questionnaire, again, you'll get the slides and you can run through it. And if you feel like you're intermediate to high risk, then maybe talk to either your primary care doctor or to your Parkinson's doctor about whether it'd be helpful to get a sleep study. And why is this important? Because sleep apnea affects more than just snoring and the quality of your sleep. It affects how you feel in the daytime, if you're drowsy, if you have headaches, it affects your thinking, your mood. At night, if you have untreated sleep apnea, it can increase your need to go to the bathroom. It can increase your blood pressures. There's so many things untreated sleep apnea can affect. And from a bigger picture standpoint, this is what can happen with untreated sleep apnea. It can contribute to higher risk for high blood pressures, causing strokes, cardiac issues, memory issues, diabetes, and then increased traffic, workplace accidents. So multiple good reasons to look into if you have sleep apnea, if your scores on that stop bang questionnaire were on the intermediate to high side, okay? But you might tell me, oh my gosh, I could never wear a mask like this. And yes, I will admit that I've never worn a CPAP mask. I have been told by certain patients that it does feel like you're in, was it like or air hanger with the or sitting right next to a fan. There's just different people's perceptions of the CPAP mask wearing it. I will say that hopefully technology has improved over time and that there are easier masks to wear that are less cumbersome and can allow you good quality sleep at night. So talk to your doctors. For medications, often we will prescribe melatonin. It's natural. It can help with normalizing your circadian rhythms and improve your REM sleep behavior disorder. If that is not enough, sometimes we will use something called clonazepam or some other benzodiazepine. So they work kind of like alcohol, and they can help with REM sleep behavior. We just are a bit more hesitant to use it in patients who have higher risk for falls and cognitive impairment because they can worsen both. Okay, next up, constipation. So actually the next three, so constipation, bladder issues, blood pressure issues are part of the autonomic nervous system. So this is the automatic nervous system, the part that you can't really control actively. And they include the different systems of sympathetic, parasympathetic, and your gut. So sympathetic is if you saw a tiger and we're trying to fight it or run from it, that's the nervous system that it activates. The parasympathetic is when you're relaxing on the couch. That's the sympathetic nervous system, parasympathetic nervous system that acts up. After, maybe you had a good meal, and that's the nervous system that will be busy afterwards. And then, yes, the gut, again, is also innervated by this autonomic nervous system. It affects many different functions of your body, including maintaining your blood pressures, heart rate, your breathing, digestion, your urination, salivation, and sexual function. So it's a very important nervous system. I'm not going to go through this slide in total, but again, this just shows the different types of the nervous system. The one that increases your fight or flight responses or your rest and digest responses. And they're essentially opposite. One increases salivation, one reduces salivation, one increases digestion, one reduces digestion, one increases blood pressure, one decreases blood pressure. So constipation is part of this autonomic nervous system, and it can happen early on in Parkinson's, even before the stiffness develops or the tremors develop. So we call it often the prodromal feature of Parkinson's disease. So again, before motor symptoms develop. About 50% or so PD patients will have issues with constipation, and is defined as having less than 3 bowel movements a week. So there are many non-pharmacologic treatments for constipation, starting off with my favorite word, exercise. That's very important for constipation. You can also adjust your diet. So increase your fiber intake, make sure you got some good fruits and vegetables, increase your hydration, which I think a lot of us could improve on, including myself. So try and drink 8 glasses of water a day. APDA actually has a wonderful website, a handout for constipation. So if you ever want to just Google APDA constipation handout, it's a great resource to understand what kind of foods would be helpful for constipation, what foods to avoid, what kind of medications might worsen constipation, what type of stool softeners, etc., can be available. So look into that. There is a good cocktail that you'll see online that people will often reference for constipation that's natural and includes bran, prune juice, and applesauce. So you can definitely try this if just eating healthy doesn't seem to keep the constipation at bay. And don't worry about copying this. Again, you'll get it on the slides. This slide just shows all the different types of things we can order for you to try and keep your bowels regular. So we can order things like Miralax, which many of you are probably on. And what this does is it keeps water in the gut so your stools are soft and not too dry. There's the bulk forming medications like Metamucil. There's the ones that stimulate your gut to move. They're the ones that make your stools actually softer. So many different ways we can try and maintain your regular bowel movement and bowel regimen. Okay, so next up, bladder issues. So bladder issues also are quite prevalent in Parkinson's patients. They can be either due to Parkinson's disease and or other conditions associated with aging. For instance, your prostate, gynecological issues, diabetes, etc. It's always important just to make sure there's no other reasons for why a person might have bladder issues. For instance, if all of a sudden you're having trouble urinating, it could be from a urinary tract infection. So just something to be aware of. The most common issues may include urinary urgency and incontinence issues. When it comes to urologic issues, often from my standpoint, I will manage them, but I will often refer them to my patients to a urologist just to make sure there's nothing else urologic going on. So how do we manage bladder issues without medications? So, your issue is you have to pee, and when you have to pee, you got to go to the bathroom right away. This is a very common complaint my patients have. So a way to do that is to just regularly empty your bladder. So say every 2 hours, I'm going to just go to the bathroom, try to urinate, and so that my bladder will never be overfull. Using Depends can be helpful. It's as a protective mechanism, especially when you're out and about, that you don't have an accident and have to change your clothes. At night, it's helpful to have bedside commodes or urine bottles so you're not rushing to the bathroom and having a risk for falling. Trying to limit caffeine, alcohol, especially at the end of the day before you sleep, can be helpful in reducing your urinary issues. And then importantly, pelvic floor physical therapy exercises can improve the strength of your bladder muscles and allow you to better control your bladder. These are just different types of pelvic floor exercises. Again, you have your slides and you can look at these a bit more, but importantly, and I do not know if this is the case for all attendees, like is this only for Northwest Parkinson's patients? This will be probably a Jen question. So we have a pelvic floor strong series coming up starting March 27th. And it's basically a wonderful pelvic floor therapy course to help strengthen the pelvic floor muscles. So again, it's posted by Northwest chapter. It's all virtual. So I do not know if, for instance, the Virginia or the Alaska people can join, but assuming they can. I'll let Jen comment on that later. So for bladder issues, when you need medication, so most commonly, the one to use is oxybutynin, mostly because insurance makes you start with that medication. It does reduce bladder contraction, but it can cause cognitive issues. So it's definitely not my favorite medication to use for my patients. Thankfully, there is a newer medication, mirabegron or Myrbetrix, available, and it works in a different mechanism, so it doesn't affect cognition. The main side effect is it actually raises your blood pressures. So I've had much better success in improving bladder issues without worsening cognition with this medication. I think from an insurance standpoint, some insurances, it's still costly, but it's getting cheaper, I think, by the day, just because it's been out for a period of time now. So something to also ask your Parkinson's disease doctor if you're thinking you're at the point where you need to try medication. Okay, we're going to do orthostatic hypotension, and then we'll take a quick stretch break. So orthostatic hypotension. So this is known as positional hypotension. So dropping blood pressures when you change positions. So normally when we stand up, change positions from lying to sitting, sitting to standing, our blood vessels need to contract to maintain blood pressure so that you can get enough blood flow to the brain as you stand up, and gravity tries to pull the blood downward. This response might not be as fast in Parkinson's disease patients. So it's defined as a drop in your blood pressure within 3 minutes of standing up. So for your blood pressures, there's the top number and the bottom number. The top number is the highest blood pressure you have when your heart beats and pushes blood through the body. We call that the systolic blood pressure. When that drops by 20 points, you have orthostatic hypotension. The bottom number, which is the diastolic blood pressure, that's the lowest blood pressure you have when your heart's relaxed in between the beats. If that number drops by 10 points, you also have orthostatic hypotension. So if you tell your provider that you feel lightheaded, especially when you stand up, often we'll have you do orthostatic vitals, which is where you get your blood pressure checked when you're lying down and then standing up after a couple minutes. Why is it important? It's because it can contribute to falls. You can imagine if you stand up, you feel a little bit woozy, lightheaded, off balance, you have higher risk for falls. Risk factors for having orthostatic hypotension include medications. So in addition to Parkinson's disease, the carbidopa-levodopa you take can drop your blood pressures and cause you to have this blood pressure drop. Not getting enough hydration in you can cause this issue. Being out in the heat can cause this issue. Lying down too long can cause this issue. As you get older, you have a higher risk for this issue. And again, the different symptoms that can happen when you stand up too quickly and your blood pressures drop include lightheadedness, dizziness. You might suddenly feel weak, tired, nauseous, have some blurred vision, and just feel really off again when you stand up. So just be aware of this. Again, there are some things that can cause this blood pressure drop to happen beyond just having Parkinson's disease. Drinking lots of alcohol can worsen this. Antidepressants can contribute to this. Blood pressure medications can. Parkinson's disease medications can. Diuretics, so you might be on a water pill. That can, like furosemide, Lasix, that can contribute to orthostatic hypotension. Muscle relaxants, so sedatives can all do this. So just be careful that you might be on a medication that might be worsening this issue. In terms of how we manage orthostatic hypotension without adding new medications, there's many different things we can do. One, just when you first stand up, get up slowly so that you allow your blood pressures to adjust to your position change. There's also physical counter maneuvers, which I'll talk about in the next slide, how to get your blood pressures up. Wearing compression stockings or abdominal binders can also keep your blood from pooling in your gut and in your legs. Here's my favorite word, exercising can be very helpful for reducing orthostatic hypotension. Increasing salt and water intake. This is, of course, if you don't have already issues with high blood pressure and are trying to avoid the salt, you can try some increased salt. Also, try overheating because that can expand your blood pressures and make you at risk to have lower blood pressures. For instance, using the sauna too much or the hot tub, that can cause overheating and blood pressure drops. Avoid alcohol, and then also eat smaller meals. When you eat a big meal, all your blood goes to your gut to digest, and that can drop your systemic blood pressures. So these are the counter maneuvers that can help raise blood pressures. Just be very careful because some of them might be hard to do with Parkinson's because it can make you feel a little imbalanced. So just be careful when you use these, but you can do a leg cross, you can raise your toes, squat, forward lean. Again, I say this all with caution. And then clenching your thigh, abdominal and buttock muscles can also help raise your blood pressures. If trying all those other options is not effective, in certain patients, we might have to start a medication to keep blood pressures up. Because they raise blood pressures, they also can increase your blood pressures, especially when you're lying down. We call those supine hypertension. And the medications we might use include fludrocortisone or Florinef, Midodrine, or Northera. But I try to avoid these if possible, just because of the high blood pressure issue that comes with it. Okay, quick stretch break. There's a lot of information. I hope I'm not already overwhelming you, but let's stretch. And then clear the mind for a second, and then we'll keep on going. Okay. Let's go on to drilling. Let's see how my time. Okay, good. So drilling, the fancy medical term you might see is sialuria, and it's caused by actually not because you're making more saliva, but because you don't swallow your saliva that you make as much. Because with Parkinson's disease, you have a slowness and a loss of movement, and that includes reducing, it affects how often you swallow. So if you swallow less often, the saliva pools in your mouth, and that's what leads to the drooling. It's actually quite common in Parkinson's disease patients and can be very frustrating socially for patients with the drooling. A lot of people have to have a handkerchief or always wiping the sides of their mouth, and that can be very distressing for themselves. And sometimes because of the frequent drooling, it can cause some infection in the corners of the mouth. In terms of how we manage drooling, I usually start off conservative and then kind of escalate in terms of options. So starting with the most conservative measure, sometimes just chewing gum, sugar-free gum, or sucking on a sugar-free lozenge can encourage you to swallow very regularly, just because you suck on the lozenge and then you're swallowing. And so this will help swallow the saliva that you make regularly, and then you have less risk for drooling. If that is not effective enough, you can always try medications that are local to the mouth. The glycopyrrolate tablets, I have people chew them, put them under their tongue, dissolve in their tongue. And ideally, most of the medication hangs out in the mouth where you want it to work, and allows it to reduce the saliva that you make. Atropine drops are another thing that I will use under the tongue, again, to reduce the total amount of saliva that is produced. Of course, the downside of reducing your saliva is that you might have dry mouth. So just something to be aware of. The medications are not perfect. They can reduce saliva, but sometimes go overboard and cause too dry of a mouth, causing discomfort in that sense too. Sometimes to try and avoid the medication from going beyond the mouth, to just really be very targeted to just the mouth, controlling the saliva production there, I sometimes have people use those atropine drops into just drop it into a glass of water, and then you kind of swish and spit it just like mouthwash. So it allows the atropine to be present in the mouth for a short period of time, but not too much of it, so that you don't have the side effects that can happen with the medication. And beyond just having dry mouth, this type of medication can cause other symptoms if it gets into your whole body. It can affect your temperature regulation and sweating. It can make you feel confused, flushed, increase your heart rate, again, make you feel thirsty and dry mouth. So they're just, for every medication we prescribe, there's always potential side effects. So we try and limit that. And for drooling, what is helpful is just by trying to administer the medication directly to the mouth area and trying not to keep it there too long. If that is also not effective, sometimes we will have to use something like Botox. So this is the same Botox that's used for the face for people who have migraines or for cosmetic reasons. And what it does is that type of Botox, when you put it into your salivary glands, reduces saliva production. And so in certain patients who the more conservative measures are not effective, the drooling is extremely bothersome and affecting quality of life, we might consider Botox injections. And we place them in a couple of different salivary glands in the face. So the parotid gland that sits right here, and then the submandibular gland that sits below your jaw. The importance of Botox is it wears off after 3 months. So every 3 months, you'll have to come back to get repeat injections for it to keep on working. The other thing is it can weaken muscle and make muscle smaller. So for instance, that parotid gland that sits right where you have muscles that are important for chewing, over time, some of those muscles get smaller and people might have difficulty with chewing. So that's just something to be aware of when it comes to Botox injections. But they can be very helpful for patients. And we have several patients who really find quality of life improvement because they have the Botox injections. Okay, so next up, let's talk about mood issues. So mood issues in Parkinson's disease include depression, anxiety, and apathy. And mood issues can have a significant impact on quality of life for both patients and for the people around them, the caregivers, their loved ones, friends, family. It can affect sleep, worsen fatigue, and limit socialization, which are not great for Parkinson's patients. So starting with depression, it's more common in Parkinson's compared to other chronic conditions with also similar disability. There's a lack of clear relationship between how much depression you might have and the severity of your Parkinson's symptoms. So there's not always a great correlation to, like, if people have more advanced Parkinson's, do they have more chance of having depression? There's not always a great correlation there. And sometimes depression can come very early on in Parkinson's disease patients, sometimes before the motor symptoms. It can really affect many day-to-day activities and impair quality of life, affecting your sleep, appetite, interest in activities, your energy levels, and your thinking abilities. In terms of treating depression without medication, there are different options. You can do psychotherapy, light therapy, especially here in Seattle, where sometimes it's not so sunny. My favorite word, exercise, can be very helpful for mood. Massage, acupuncture, music therapy, and also support groups can be very helpful for feeling like you're not alone, that you're part of a community. If those are not adequate to manage the depression, we can always use medications. Sometimes actually the mood issues are associated with you being off your meds. So people will tell me, when they are on meds, they feel great. They feel like they can move. The world is great. But then when they're off and they can't move, they can't control their body, they struggle with their moods and they're more irritable and more frustrated. So in this case, we can try adjusting your Parkinson's medications to smooth out those motor fluctuations and minimize those off periods. If that's not the issue, we will often try an antidepressant like sertraline or escitalopram or mirtazapine to improve your mood. So do not be afraid to bring this up to your Parkinson's disease expert, whether it would be helpful to try an antidepressant. For anxiety, which often coincides with depression and Parkinson's, this can also improve with medication adjustments, because some people, when they are off meds, again, that lack of control, it affects their breathing, their mobility. They can feel like it's a panic attack. And so when you can smooth out those motor fluctuations, people's anxiety improves. Again, most of our antidepressants can also improve anxiety as well. So if you have depression and anxiety, just using one medication can often be enough. On occasion, I have a couple patients who are needing this class of medication, the benzodiazepines, like Ativan or clonazepam. These can be helpful in the right situations to really improve anxiety and improve quality of life and mood. I just am very judicious about using it in older patients, especially because of the risk for worsening cognition and balance issues. Next, apathy. So this is a special phenomenon in Parkinson's disease, and it is the loss of motivation and interest, and not because of depression. You just don't have the drive to do things. And it can be very frustrating for patients and also their loved ones. Why are they not involved in exercise classes? Why are they not going out and doing activities? So there's different ways around this. So sometimes the antidepressants can help with improving this motivation. Sometimes using stimulants, I wrote that wrong, stimulants such as modafinil can increase your energy and improve your apathy. Scheduling activities, which is really good because there's no side effect to that. You can say, hey, today I'm going to do this exercise class. It's on the calendar. I will do it. Or tomorrow I'm going to join the support group. And sometimes that accountability can help you be more motivated to be active and keep people, it helps keep you engaged. Okay, so 2 more to go, cognitive impairment and then psychosis, okay? Everyone doing okay, hopefully? Okay, so cognitive impairment. So this can present in about 20% of Parkinson's patients, sometimes at initial diagnosis. The main areas that can be affected include executive function, and that's multitasking, planning things, organizing things, problem solving things. Like when your fridge is broken, what do you do next? How do you fix it? Who do you call? People can have visual spatial issues. So where things are in space, or how to navigate from point A to point B. That can be impacted with Parkinson's disease. And attention and concentration can also be affected. So you might have had this conversation with someone, but you were not attending to that conversation and forget what was said. In terms of management of cognitive issues without medication, so when it comes to medications, especially with carbidopa-levodopa, when you have to take it so often, using like reminders on your phone, some of the medisets have timers on them and they talk to you. Those are great to keep you on track for your medications. Having a regular routine is helpful to keep you on track with daily exercises and daily activities and exercise. Brain exercises can be helpful, like reading, doing word puzzles, crossword puzzles, watching Jeopardy, anything that kind of stimulates your brain, great. Socialization is also very key. And whether that is in person or through Zoom, all great. So doing a support group meeting, that can be very helpful for socialization. Improving your sleep, because if you don't sleep well, you don't think well. And I know this as having 2 young kids. So optimizing your sleep, as we talked about earlier, can be very important. Your mood, if your mood is not great, you don't sleep well, you don't concentrate well. So mood management can definitely impact your cognitive abilities. If we do use medications for thinking, if it gets to that severity of impairment, there are a couple of medications we might use, and some of you might be on these. So these are ones that increase another chemical messenger in your brain called acetylcholine, and this can help improve thinking. So those include the donepezil, galantamine, rivastigmine. And then there are also other medications that reduce toxic messengers in your brain, like sodium, and that's memantine. That decreases the chemicals in the brain that can potentially harm brain cells. And so that's the philosophy behind the different cognitive medications that we have available. Just to note that the medications can improve cognition to a certain degree, but ultimately does not stop the cognitive decline. So I will use cognitive medications in certain patients, but I will honestly say that I don't see substantial improvement. Again, that's just my experience so far. You might have had great experience with some of these medications, but I do hope that there will be some new medications in the pipeline to help with this particular issue. And of note, some of those medications can sometimes worsen motor symptoms such as tremor, so just be aware of that as well. Okay, we're on to our last one. We're doing okay on time. Okay, last one is psychosis. And this includes issues like hallucinations, seeing things that are not there, hearing things that are not there, sensing things that are not there. They're usually benign and usually not disruptive or distressing for patients. There's illusions, which is misinterpreting things that are actually there. So I have a patient who at home had these paisley pillows, and he would always misperceive them to be hula girls. So there's actually something there. It's just there's a misperception of what's there. Then there's delusions, false, unshakable beliefs that are not based in reality, usually paranoid in nature. And these can be definitely more problematic amongst the patient and then their loved ones. In terms of treatment options without using medications, I will always ask about hallucinations, illusions, and ask if they are distressing. If a patient says they're not distressing and family agrees, I often do not start a medication for it or just a medication for it because they're not bothersome. Usually we focus on things like reassurance or turning on the lights if it happens when it's dark, or like refocusing on a different situation or object, and that helps relieve that hallucination and or illusion. But in certain patients, when it's very distressing, where they will act out against the hallucination or run the risk of hurting themselves or getting themselves into danger, in those situations, that's when a medication adjustment might be due, or starting a medication might be helpful. So there are some medications that can worsen psychosis. So dopamine agonists that people are on can cause or worsen hallucinations, anticholinergic medications, amantadine, the MAOB inhibitors such as rasagiline, selegiline, and then the COMT inhibitors like entacapone. So some of you might be on these, and these do run the risk of hallucinations, but not everyone has this issue. Just be aware of that. Sometimes the carbidopa-levodopa has to be adjusted. I really try to avoid that because there's so much importance to being on carbidopa-levodopa from a motor standpoint. So it really depends how severe the psychosis is. And if necessary, we may add on medications to combat the hallucinations. And these include clozapine, which I use very regularly, very infrequently, because it can affect your blood counts and require lots of blood draws. I more commonly use quetiapine, or Seroquel is the other name for it, or pimavanserin or Nuplazid. Those are the second two are my go-to if people are having significant psychosis issues. So Nuplazid or pimavanserin, it's the only FDA-approved medication for Parkinson's hallucinations and delusions. It was approved in April of 2016. The most common side effects, which generally speaking, patients have done well with, are leg swelling, confusional state. I know that's confusing, but generally speaking, they do pretty well on the pimavanserin. Nausea, and it can affect your heart rhythm. So we often will check your EKG, your heart rhythm, before starting you on this medication, or checking it after you've started it as well. Generally speaking, people tolerate this medication pretty well. And I think that's it. I just gave you a lot of information about a lot of different symptoms. And so I hope I did not overwhelm you like I was trying to avoid when I was talking about this in the beginning. But I do hope that you go away from this talk knowing that there are other symptoms that are associated with Parkinson's disease that are not motor. So let's go through the final key points. So Parkinson's includes both motor and non-motor symptoms. Let your doctor know if you are having any bothersome non-motor symptoms like the ones we talked about today. For each non-motor symptom, there are non-medication ways to manage these symptoms, like exercise, acupuncture, changing your sleep hygiene, etc. Sometimes changing Parkinson's medications can improve the non-motor symptoms, like changing the meds so there's less off time, so you have less depression and panic attacks, for instance. Additional medication may be used if necessary, but just be careful about the potential side effects. And then lastly, most importantly, exercise, 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 because they will improve almost all of the non-motor symptoms that I talked about today. Okay, I think that's it. I've bombarded you with a lot of information, and I'm happy to answer a few questions. I will stop my share screen.
All right, everybody, take a deep breath in.
Yep, stretch break again.
And then take a deep breath out. And shake out your arms, because you know that helps a lot.
Yep.
That was a lot of information. Thank you, Kimmy.
I know. I always struggle with this talk. I don't want to give you too much, but I also don't want to give you too little. So let's try and find the balance.
And a lot of these issues that can arise could all be talks in and of themselves and go into more details. So, this is a nice overview, and, not every symptom affects every person. Exactly. So that also makes it super complex.
I call my Parkinson's patients snowflakes. Everyone's just a little different. Everyone gets all those symptoms.
Your disease.
Yeah.
It's your designer disease. That's what I call it.
Designer disease, absolutely. So we adjust your medications and your management to what you have and what you are dealing with.
Yes. Yeah. So there's several questions that have come in. Let's see if we can go through it without too much time. Okay. So I want to go to throat and mucus and drooling. I think I'm trying to categorize these. What is the connection between PD and increased mucus in the throat?
I get the mucus question a lot because a lot of people tell me like, yeah, they feel like more stuffed up. I don't know if that's directly due to Parkinson's or not, because sometimes there's other reasons to have kind of like postnasal drip and mucus and all that stuff that might not be directly Parkinson's related. I know the drooling for sure, that is the most common type of secretion issue that can happen and be a struggle for a Parkinson's patient. When it comes to mucus, yeah, that's a little bit tricky. I can't say, some people have allergies and that's why they have more mucus issues. It's something that I would just always bring up to your primary care doctor, Parkinson's doctor, to see if there's reasons for your mucus causes, and if there's ways to manage it either through like using like anti-allergy medicine, which is what I need, or something else to reduce the mucus. Those are my thoughts on that.
Okay. What do you suggest for drooling at night?
Drooling at
Issues
night,
with
yeah.
a wet pillow.
Yeah, I actually had that comment from a patient last week, and so we were troubleshooting that. So a lot of people drool at night, even who don't have Parkinson's, because at night you don't swallow as much because you're fast asleep. So when you wake up in the morning, your pillow's wet, you're like, oh my gosh, what happened? So I was talking to this patient about what to do, because they don't drool during the day, they just drool at night. So one option was to actually, you probably don't want to suck on a lozenge or chew gum sleeping. That's probably not a good idea. So my plan with that patient was to actually use the atropine drops that I talked about just at night. And because she's a very petite lady and I didn't want her to have any systemic side effects, we were going to try the mouthwash to start off and just swish and spit at night and see if that reduces the drooling in the morning. So that would be one recommendation, doing like the drops or the mouthwash and see if that reduce the drooling in the morning.
Mm-hmm. And APDA, I don't know if this is addressed in this, but we do have a brochure about oral health in Parkinson's disease. And it does, I think, address some of this drooling and swallowing and mucus and all that stuff that has to do with your oral health, because your oral health is quite important as well. So
absolutely.
So there is one of those. I guess I'm going to go to this question. Are there ways to know how low the dopamine is in your brain? And does knowing the amounts influence medication?
No, yeah. So people ask me, can you test your dopamine levels and see if they're lower? Unfortunately, you can't. That's why you'll see that your Parkinson's doctor never ever orders you a dopamine lab, because there is not such a thing. So there's really no utility, because importantly, you may have dopamine in your system, but it may be different in different parts of your brain where you really need dopamine. I don't think I said that very well, but essentially it's very hard to monitor the levels of dopamine, and it's not really helpful for us clinicians to monitor them to adjust your medications. We basically define how much dopamine you need by how you are moving, how you're looking, and go up on your carbidopa, levodopa if you look like you're under medicated. So that's how we manage what we perceive is your dopamine, just by how you look, but we do not test dopamine. And unfortunately, I don't know if that might change down the road, but right now there's no test for dopamine.
Right. What I've heard, and maybe you can, is that if you're able to track your symptoms a little bit with like a symptom tracker app or a piece of paper, then you kind of know at least where your meds are going and where your dopamine levels are as far as how you're feeling.
Right.
Yeah.
Right.
So we've got neurogenic orthostatic hypotension, and then you have people that have supine hypertension. So how do you simultaneously treat those if somebody has both of those issues? And if supine hypertension is not treated, how prevalent is stroke?
So you're saying that these patients tend to have the low blood pressures when they're up and about, but then when they're lying, sleeping in bed, their blood pressures go super high. So this happens especially with our patients who are on medications for orthostatic hypotension, like midodrine or Florinef or Northera. So ways we do manage it, if we try to minimize the difference in position. So instead of lying flat in bed, we often have people raise the head of the bed, and that reduces the difference in the position from lying to standing, and that helps with reducing high blood pressures. Let's see what other things we can do. So other things, I often, if people happen to be on those medications, try not to have them take a dose at bedtime because they'll be sleeping and there's not as much utility to using one of those blood pressure meds at night where it just tends to raise their blood pressure. So that's another way I'm trying to manage and balance things out where they're not too low in the day and not too high at night.
Okay, thanks. What do you know about the I'm gonna say it wrong, rivastigmine patch for
rivastigmine? Yeah.
Yeah, for mild cognitive impairment. And what are the risks and rewards at this point with that?
Yeah, so the rivastigmine patch is one of the most common thing I do prescribe for Parkinson's patients who have cognitive issues and also some issues with hallucinations. And what it does, again, is it increases a chemical messenger in your brain, not dopamine, but acetylcholine, and that can help improve thinking and concurrently improve your perception of things. So like the hallucinations, delusions, the illusions. I personally really like using the patch, and a lot of our geriatric psychiatrists also use it. What's nice about the patch is it's a patch, you put it on, it's a daily patch, so you take it off and switch it out per day. The benefits of it is sometimes it has a little bit less systemic side effects comparing to like taking a medication by mouth. So a little bit less GI symptoms. So I've been gravitating to using the patch a lot. I think the only major downside of the patch is that some people get skin irritation and cannot tolerate the patch. Then I will convert to the oral medication formulation of it. But I really do like the rivastigmine patch. So if that's something that you are interested in trying, definitely talk to your Parkinson's doctor about it.
Okay. There was another question with memory. Some of the over-the-counter memory enhancing pills advertised on late night TV. Do you have any thoughts on those?
Yes. So supplements, I generally have like a general response to supplements. There's just not enough evidence on supplements in general. That's just how it is in terms of research studies. And the other thing is they're not regulated. So there's all different brands of supplements and you don't know what the ingredients are in this supplement versus this other supplement. Generally speaking, supplements are fairly safe. So taking them shouldn't hurt you. So I say if you want to take it, I generally am fine with it. I just don't know how helpful it will be. So feel free to ask me, but that is usually my response. And people will take them and I'm totally fine with them. But I just, again, don't know how potent they are. For instance, like mucuna prurens is the one that is brought up a lot for Parkinson's disease. You might have heard of it, Jen. People might bring it up.
Yes.
And people ask me, how do I dose this? Which brand is most effective? And I really can't comment just because it's not something that is regulated, and brands will have different amounts and there's just not enough studies. But if you find it helpful and you're not having side effects, I usually am fine with taking supplements.
Yeah. Okay. Does DBS, deep brain stimulation, for those of you who don't know, does that tend to improve non-motor symptoms?
It tends not to impact non-motor symptoms. We, for DBS, focus and target on the motor symptoms. That's how we program the DBS. So it ideally improves your stiffness, your slowness, your tremors. But I think secondarily, it can improve things like pain, for instance. So if you have a lot of pain, that's related to your on-off issues. And the DBS, which is like getting med all the time by the stimulation, that might improve your stiffness and your slowness and improve your pain. So yes, like pain could improve. Other things like your mood, because you're not having as much on-off issues, that might improve your mood and your anxiety because you're not having these off panic attacks. Some of the other ones though, like, are sleep. So maybe you're not feeling as stiff in bed anymore because you have DBS. And so like when you're moving about in bed, you're not waking yourself up from it. So maybe that will improve. So it really depends. It depends on what motor symptom, non-motor symptom you're talking about and how related it is to some of the motor symptoms of Parkinson's disease.
Okay, great. Thank you.
Yeah.
Speaking of sleep stuff, REM sleep disorder, is the beginning of REM sleep disorder a sign that PD has started, even if it was 4 years before resting tremor started?
So yeah, that is our understanding of REM sleep. That's what we're thinking, that REM sleep behavior disorder is one of the prodromal features of Parkinson's disease. Granted, not everyone with REM sleep develops Parkinson's, but there seems to be a potential link, and that's being studied a lot in different studies. For instance, the Michael J. Fox funds the Parkinson's Progressive Marker Initiative. I don't know if I said that right, PPMI, and that is looking at patients who have prodromal features, and the other prodromal features, the loss of sense of smell. The other one is, of course, the REM sleep behavior issues, and whether these patients eventually develop Parkinson's, and when do they develop Parkinson's. So it's a very interesting connection. So I often say, yeah, if a patient comes to me with clear Parkinson's disease, they probably have Parkinson's disease years before they had the tremor start. They probably have Parkinson's, who knows, 10 years ago when they stopped smelling things as well, or they were moving and acting out their dreams at sleep, or they were having constipation issues. The motor symptoms often come later on, and that is our goal, to try and figure out if we can find patients and treat patients before they develop the motor symptoms, because oftentimes that's too late to reverse the changes that happened. So we want to catch patients early. So REM sleep is one of those things we're trying to use to see if we can catch patients early by noticing that they have REM sleep behavior issues.
There's actually, in our next Pathfinder, which is going to the printer today,
Good.
Is an article about a researcher that APDA has funded who is studying REM sleep disorder and trying to make that link to Parkinson's, and then how can we do early treatment. So that's coming out. So stay tuned, folks. Okay, there are more questions. How's your time here?
I may have to leave in a couple minutes because I have clinic.
I thought so. Yes. So I'm trying to figure out some general questions. Back to sleep. Blue light reductions on devices.
Yeah.
You know what the recommendation is? How long before bed to stop using devices? Is there a general?
Just when you get to your bedroom should be just your sleeping
your sleep sanctuary.
Your sleeping sanctuary. Yeah, I actually had this again last couple of days ago. One of my patients who's now getting kind of like cognitive behavioral therapy for sleep. So they were talking about with the therapist how to maximize your sleep hygiene. The bedroom should only be for sleep. Don't do anything else. If you want to play with your iPhone, TV, why not do those outside the beds, outside the bedroom, so that when you walk into your bedroom, your brain says, I'm here for sleep. So I would say, yeah, it's not like how many minutes before you go to bed, it's more like in the bedroom. In that situation, you should not be playing with your iPhone or your iPad or watching TV, because that will alert your brain more and make it harder to fall asleep afterwards.
Okay. All right. I'm going to go to one last issue that I don't think you addressed. Heart issues with Parkinson's. And there's someone's asking about an angina. And the other question is a little bit about, I think this is more related to anxiety and my non-medical assumption, but when she's out running errands, she starts breathing too fast and shallow, and the body gets stiff and starts to limp, and wanting to know if that's normal or, what that is. So it's kind of related to heart. I don't know if you can address those two together.
Right. So directly heart, for Parkinson's disease, I would say the most common like heart related issue is that it can affect your blood pressures, like we talked about earlier. Heart rate wise, there's not as direct connection. People can feel like they have trouble breathing. That's one. I think that when you were mentioning, that person was out about doing errands and they feel like they have trouble breathing. I do hear people feel that when they are wearing off of their meds, because they just can't control their chest muscles breathing. They have more shallow breaths, and that just makes them feel tired and kind of out of it. So my question to that person is, do you feel like that tends to happen when your medications are wearing off and you're due for your next dose? Because if that's the case, then that might warrant you adjusting your Parkinson's meds a bit or having a rescue. So some people who feel like they are slowing down, their breathing is becoming more labored, they're getting tired, they're wearing off. Sometimes I'll have people just chew like the carbidopa, the immediate release yellow round pill, and that'll give them a boost of dopamine. Maybe they're, because you were talking about dopamine levels, their dopamine levels are low, so we got to boost them back up. So using that can help boost you back up and make you feel like you have control again of your body and get you out of this funk where you feel like you can't control your heart, you can't control your breathing, and you can feel more comfortable again. So that's my recommendation to that. I think one person that was bringing up her issues.
Okay,
but definitely bring
great.
that up to your Parkinson's doctor for sure.
Yeah.
Angina is chest pain. I can't speak much directly that Parkinson's causes chest pain. Oftentimes I will find that when people have the diagnosis of Parkinson's, everyone says that's like every symptom is due to Parkinson's disease. Like,
I always tell the newly diagnosed, just blame everything on Parkinson's. You can't really actually, but yes.
you can't always blame it all on Parkinson's. So I think that's an important mindset, because you don't want to miss out on things that should be looked into or managed, like angina. If you have angina, if you have true chest pain, that is something heart related that needs to be checked out from like a cardiac standpoint. So yes, it could be from Parkinson's, but not always. It could also be from Parkinson's and another thing. We call that multifactorial. For instance, like the urinary issues. Often it's not just Parkinson's, it may be Parkinson's and your prostate, etc., causing your issues. So,
and there was a question about kind of addressing sexual dysfunction, and it's the same thing. It could be Parkinson's, it could be something else, and you know, it is all related to that GI, urinary, that whole area. So, and I will answer the question of the pelvic floor series. They're starting. It starts on Monday. It is a virtual class, so it is open to everybody. It is a 10-lesson program, and we really want to encourage people to register for it if they're committed to actually doing the program, because it can make a huge difference, but you got to do it. You got to show up, you got to do the exercises, you need to learn what you need to do in order to strengthen that pelvic floor. So
is there a max in terms of people who can register, or no?
There is not a max of people who can register. We'll see how this goes, because it is virtual.
I was just curious.
But we will be cutting registration off on Tuesday, because the first class is Monday. So that's on our virtual calendar, the APDA one. So that's a great thing.
Definitely sign up. I would say I have a lot of patients who struggle with urinary issues, and again, you can try medication, but trying to improve the strength of your bladder muscles can't hurt.
That's why we're doing it. So yes, absolutely. For men and women. So, you know, it's great. The other thing that I want to tell everybody who's still here is if you're in the Puget Sound area, Dr. Kimmy Su on May 5th, as well as Dr. Gilbert, our National Medical Director, are going to be at our first in-person conference in 3 years in Tacoma. It is called Live Well, and will be an all-day event in Tacoma. Registration opens tomorrow, and we have about 15 speakers lined up for this event. So I think it's going to be a really, really terrific day. So if you're in the Puget Sound area, come join us in Tacoma on May 5th. So I am going to send Dr. Su's slides out next week, along with a link to the video. I'll also link to where our publications are, so you can go to that like constipation handout that she mentioned, as well as like there's a handout on drooling. There is a handout on urinary issues. There's just all these little
they're great. They're like one pagers. There's one on orthostatic hypotension that's really good too. So yeah, look into those.
Yes, great. So we are going to wrap up. We went long today. So thanks to those of you who have stuck it out for the whole thing. And thank you, Dr. Kimmy Su. This was very informative. And as one of our participants said, very clear and helpful. Thank you. So I totally agree. It's a lot of information, but important just to know these things that can happen so that you can tackle them. So thank you so much for spending your morning. It's morning here, almost afternoon. Any parting words for our audience?
So again, this talk, I hope I didn't overwhelm you. Feel free to give me feedback. I always love feedback on my talks to further improve it. So send feedback to Jen, and Jen will forward it on to me. So we're gonna.
Oh, and I will be putting a survey in your post-event email, so you can answer the survey and give Dr. Su direct feedback that way.
Yeah,
I forgot to mention.
I just wanted to make this helpful for y'all. So the only way I really know is just for you to give me feedback. Okay.
Yeah. Excellent. Well, you have a wonderful day, and thank you so much for doing this. We'll see you again. Well, we'll see you on May 5th when you're talking, but maybe in the virtual world another time. So
I'll see you tonight, actually.
Well, I will see you tonight for a meeting. So, but everybody else on this call, we will see you again at another virtual program or in person. And thank you for joining us today. We hope this served you, and feel free to reach out if you have questions or need assistance with anything. So thank you, everyone, and have a good day.
Bye-bye.
Bye.